Uh, Good morning, and it's a proud privilege to welcome Dr. Tepper with us, and he's an associate professor at the University of Michigan, USA. Welcome to India, and welcome to the Bengal Liver Summit. I hope you had a comfortable flight, and this is not your first visit to India.
It is not, but the hospitality here is unmatched, as is this conference, and it is a true privilege to be here with you today.
Thank you very much. And so we have gathered here today to discuss about diet and nutrition in patients with cirrhosis. Now, there are a lot of myths about diet and exercise in patients with cirrhosis, and as the disease advances, especially in decomp cirrhosis, a lot of people tend to restrict their diet. The physical activity tends to come down over a period of time, and they are kind of restricted to their homes. What is your thought about it? I mean, how should a clinician or a hepatologist approach this? And so let's first talk about diet. How do you prescribe diet to your patients of cirrhosis?
Yeah, this is the most important question when it comes to the management of decompensated cirrhosis. And when a patient presents, for example, to your clinic, I'm not worried about them at all. But instead, out in the community, in India, and definitely in the United States, most clinicians will share with patients myths that put them at risk of untimely death. And I think we need to talk about two. One is about sodium restriction. Generally, when a patient with cirrhosis comes in, irrespective of the presence of ascites, they're told to restrict sodium. But even when people have fluid overload, there are trade-offs to consider. So when it comes to sodium restriction, we have to make sure that we are optimizing their diuretic dose and making sure that if they're cutting down on salt, they are not giving up on the necessary calories and protein that they need to consume to keep them alive. Most people who achieve sodium restriction actually miss targets for calories and protein, becoming malnourished, increasing the risk of falls, hepatic encephalopathy, and death.
So let me just interrupt you here. And so what kind of salt prescription diet do you give? Like if you have compensated cirrhosis, you have early decompensation and advanced decompensation. So it's like 6 grams, 2 grams, and what about rock salt, black salt, and other varieties which are available in the market? Because you tend to tell them that, okay, you have to restrict salt,
Yes.
but then they go on to the alternatives and take black salt and other things.
Yes.
So how do you tell them, and what is the kind of stuff which is given to them?
So I don't think there's a special salt that's somehow healthier, and in fact some salts have a high amount of potassium in them, which can pose significant risks. So in general, I keep my messaging very simple. I make sure that people are not adding salt to their food. I try to help them avoid preserved foods in packages or cans, but I focus on the things that really matter: healthy fruits and vegetables and high protein foods. And if their fluid starts to build up, I'll increase the diuretics so that they can meet those important goals.
Okay, so generally, do you restrict salt in all your patients of compensated cirrhosis also? It's like
No.
a normal diet for them?
No,
Normal
normal diet. I focus on heart-healthy foods. I focus on fruits and vegetables, lean proteins, restriction of carbohydrates if they happen to have fat in their liver, MASLD. But salt is not the most important thing that I'll address in my limited time in my busy clinic.
And what about processed foods? You know, there is inadvertent salt in that. And a lot of people tend to take processed food,
Yes.
frozen food, and so on.
Yeah. So obviously, there's more salt in packaged foods, but I think that that's level 2.0. Okay, we need to focus on the basics for most of our patients. And once we have set the key goals of protein, lean protein, and fresh fruits and vegetables, then we can help educate people about where salt comes from. Most people are not accountants, and they can't add up all of the sodium on the packages. But over time, as we build a relationship and we work through the management of their conditions longitudinally, I'll help them try to figure out how much sodium there is in these packaged foods so they can make the right choices at the store.
And the last question, how much is kind of, total restriction about salt? or it's like you tend to restrict them to 2 grams, and how do you suggest them, okay, it's like 2 grams, and how do the patient decide it's 2 grams, 4 grams, 6 grams?
You know, the truth is that there is no evidence for the 2-gram restriction. If you recorded me in clinic, you'd hear me talking about a 2-gram restriction. But if somebody comes in at 3 or 4 grams while meeting all of those other goals, I'd be okay. I can always increase the dose of diuretics if they're becoming more swollen, if the rest of their body is being nourished. So 2 grams is a general rule of thumb, but we're not going to hold ourselves to that like it's written in stone.
Okay, so message here is that restriction has to be there, and it should not be very severe kind of restriction for the patients.
Agreed.
Okay, so let's move forward. Another myth about diet is that so patients should not take proteins.
Yes.
Because the liver is already affected, and if you're taking a lot of proteins, it's going to further get worsened.
Yes.
So what is your thought on that?
Yeah, and I think most patients with liver disease are told to restrict proteins. This is a myth that persists around the world. But that in truth, when you restrict proteins, you will become wasted. You will develop sarcopenia. And your muscle is so important, not only in protecting you from falls, but also it's metabolically active. It's clearing the body of inflammation. It's clearing the body of toxins like ammonia. So if I were to have a lot of meat, then my ammonia level might go up a little bit. But I could be doing complex math with that ammonia level, okay? It's definitely possible. But over time, if you nourish the muscle, it will keep the average ammonia level a little bit lower, reducing the patient's risk for encephalopathy. And so, I would never restrict protein. Now, the next question, I think maybe I'll turn it to you.
No.
Do you tell people to only have vegetable protein, or do you think animal protein is okay?
Okay, so in India, a lot of people are vegetarians. So we tend to tell them that there is no need to restrict. If you're a vegetarian, you can take whatever protein you have. But then animal protein versus vegetable protein, there is no such myth about it that animal protein is better or vegetable protein is better. For us, both are equally good. From the hepatologist point of view, I would say that if you can take it from the vegetable, it's good enough. If you can take it from the animal food, it's also good enough for us.
Yeah.
Though there is some data which suggests that vegetable protein might be a little better digestible. But then I would not recommend to my patients. I would say that if you're a vegetarian, take vegetable proteins. And if it is you take non-vegetarian food also, then take animal protein as well.
But where is the vegetable protein coming from? In America, I will talk to people about tofu. I will definitely talk to people about cheese or paneer. I'm not sure if that's allowed in all vegetarian diets. I'll talk about special supplements that have soy or pea-based protein. But it's kind of hard. So what do you recommend?
Yes, so I think in India, obviously it's very difficult to give them high protein diet if it's a completely vegetarian diet. Now, what we tend to prescribe them is a lot of paneer, okay. Second is obviously tofu is also available in India. We tend to prescribe a lot of pulses to them because it's a staple diet. People tend to have rice with a lot of pulse, and pulses have a reasonable protein content. So black grams, and then you have certain foods which are kind of supplements. Now you have a lot of protein supplements also available, as you said, whey and soy protein. So we tend to prescribe them if the intake of a patient is less with the diet which they're consuming. But then yes, we need to supplement in most of our patients because overall the protein content which they're getting in India is less as compared to the West, and especially when they are completely on a vegetable diet.
Yeah. One other point I would like to make is that it's likely that the amount of protein a patient needs is roughly 1 gram per kilogram actual body weight every day. And I can tell somebody, you need to take 77 grams of protein. But again, that's an abstract number for most people. And I have to work through a sample diet over the course of the day. When you wake up, what do you eat? And the average patient in America will tell me they have oatmeal or cereal. And I have to explain, there's not much protein in that. And then they'll try to impress me and they'll say that for lunch they had a salad because salad is healthy and salad has protein. But there's no protein in lettuce. So I actually have to come up with some alternatives. And there's a divide across socioeconomics where the clinician might not be fully aware of what's available or feasible for the patient. And I have to think through what can they afford. And it costs me about 2 to 5 minutes to explain a sample diet. I will definitely refer patients to websites or a nutritionist, but I think it's absolutely important that we spend that time to meet patients where they are, to explain what they ought to be buying.
So one thing what we have noticed is that in a busy OPD, like we see a lot of patients, sometimes it becomes very difficult for us to prescribe them the kind of diet which you have suggested. So what we have started doing is we have a dedicated nutrition clinic running in our hospital, in our clinic. We tend to send all our patients to the dietitian, who's a liver dietitian, who's a trained dietitian and who treats our patients. And she gives a diet prescription to them, as you said that the protein has to be there, which would be 1 gram per kg. And how do they achieve that? And then they tend to follow up also. So that's how we've been trying to achieve the goals of protein in our patients. What do? Do you send all your patients to a nutritionist, or it's like you prescribe the diet?
So from a global perspective, I need to tell you that that is not available in most general hepatology clinics in the United States. There are not nutritionists in most clinics. We are very fortunate that we do have one, but she's not there in clinic every day. There's a waiting list. So I will provide people printouts, PDFs, and links to websites that have been prepared by experts that will have sample shopping lists or ideas for how much protein people should be eating. And that's the best that we do in the United States.
Okay, so do you tend to restrict proteins in patients who have hepatic encephalopathy? That's again a myth.
Never. That's against the law.
Okay,
So we're not talking, if someone shows up in coma, right? I'm not giving them meat intravenously, right? But again, the supportive care of the patient with hepatic encephalopathy includes a very high protein diet. Juan Cordoba, the great Juan Cordoba, a giant in our field of hepatic encephalopathy, proved that up to 2 grams per kilogram everyday protein was safe and did not hasten recurrence of hepatic encephalopathy. So I think we know, without a doubt, that protein is safe in patients. And for all the reasons that we've already reviewed, restricting protein has other ill effects.
So I think the message is very clear that there is no restriction of proteins in patients who have hepatic NCAF also.
Correct.
Okay. Let's talk about fats. What about fats? How do you prescribe fats in your patients? There is some data which is coming up that fats might be good for the liver if you're not able to supplement adequate calories and proteins.
Yeah. So, you know what? I pick my fights wisely, right? And a lot of our patients in this day come in with some degree of obesity. But when one has decompensated cirrhosis with a life expectancy with a high risk of death in the next year or two, I'm not focusing on low-fat diet. In fact, most of our patients don't want to eat at all. And we're telling them, in some cases, to restrict sodium. What do they want to eat? I will say, what is delicious to you? And if fat is the way that I get them to eat, so be it. I do not choose to restrict fat for most patients. There are some people where their BMI is 45, 50, and I need them to get a transplant in the next 6 months, and there with a nutritionist on hand, I will carefully, slowly, judiciously help them reduce calories to a degree. That is not the case for most patients, and restricting fat is not worth our time.
Okay, and what about MASLD? Now you have so many patients of MASLD going around. Some would have compensated disease, some would be having obesity, diabetes, and so on. So what is that kind of diet prescription for them?
Yeah. So I think the messaging should be clear for us. The liver hates alcohol, it loves exercise, which we should talk about, and it hates carbohydrates. And the way that I help people lose weight is by not drinking sugar-sweetened beverages, juices, and sodas. And here we are reporting from the City of Sweets. where I've already indulged several times in many desserts. I know how tempting it is, particularly here, but the number one enemy for us is carbohydrates. And so what I will do is I will focus on carbohydrate restriction. And there's a lot of evidence that if you can get some calories down a little bit, you reduce carbohydrates, even a high-fat, high-protein diet is associated with weight loss. And that's my method.
So my prescription would be that I would tell them that restrict the sugars which you take. As you said that, we tend to consume a lot of sweets and a lot of sugary drinks also. So tell them to restrict sugars and things would come into place.
Yeah.
And as you said, I think exercise becomes very important for all our patients. So let's talk about exercise in patients first with MASLD. What is the kind of prescription you tell your patients?
Yeah, I think it's first worth calling out that although we live thousands and thousands of miles apart, we're not saying anything different. We're on the same page about this, and I hope that's the case for exercise. We'll find out. So when somebody comes in with MASLD, I think the main thing I try to get is to find out what kind of exercise they're willing to do. If walking is all that is of interest to them, I don't think that that's the best thing to do, but if it's something, then I'll ask them to increase their steps over the course of the day. Ideally, I want them to huff and puff and sweat. But the best kind of exercise is resistance exercise. As the muscle gets tired, it will begin to vacuum fat out of the visceral adiposity and out of the liver, and that's a good thing. The more muscle-based exercise, the lower the risk of things like falls, so that's my favorite exercise for the patient with MASLD cirrhosis.
Okay, so I think the common myth is that patients have already liver disease, they are already fatigued, so trying to restrict their activity so that that doesn't worsen. But it's the other way around. You need to tell them that you need to exercise, improve your functional activity, improve your muscles. That's what the message has to be, that you need to exercise in whatever way it is possible, whether it's walking, whether it's kind of some sort of resistance exercise. I suggest my patients, okay, you go for a walk, and if you can go to the gym, that's the best. And maybe you start with some light exercises, and then little bit of weights also you can add. And especially in patients who've compensated cirrhosis and MASLD. If they tend to lose fat and increase the muscle mass, definitely they're going to improve. So that's what we tend to do, that it's very difficult for sometimes patients to take out time for exercise. You need to tell them again and again that exercise is very important for you, and it might be any form of exercise, resistance, or maybe aerobic exercises, or even Zumba, or maybe yoga, right? Or maybe some sort of any other physical activity which can be done.
So, the average patient with cirrhosis and portal hypertension is at very high risk of being glued to their chair. There's a 1 in 5 risk of falling, cracking their head, breaking their hip. And coming up with small, attainable goals to ease them off the couch and get them moving is absolutely critical. And I am sitting here with an authority who has established some of the benefits of yoga, and I recommend yoga to my patients. I recommend gentle exercises. One of the other exercise forms is called Tai Chi. And these are exercises that people can do to get used to the idea of moving about. It can begin in the chair and then slowly start with rising from a seated position and then doing other exercises. It can be done in the home, watching a video or a YouTube video or something on Zoom, and then it can be done in the community or out in the park. And these exercises are probably a gateway drug to more adventurous exercises, and they are proven to reduce things like falls.
So I think there is sufficient data to suggest that diet and exercise both improve the outcome of patients with cirrhosis. And whether it's a simple exercise versus a complex exercise, it depends on the kind of patient you have. So compensated, you might go a little beyond simple exercises, but then decompensated, let's start with simple exercises, and that is also going to help. So when we talk about sarcopenia and frailty and liver-related outcomes, what is your thought?
So I agree with you 100%. So it's slow and steady. We're in this to win this. And just like we were talking about with diet, we have to meet people where they are. So I will prescribe an exercise that involves an incremental change from the patient's baseline. I will hold them accountable to expectations that they increase their step count, they increase their activity, and I will push them just to the place where they're uncomfortable so that they can make the gains that are associated with a reduced risk of complications.
Okay, so there are some lot of app-based modules available or AI-based modules. Do you have something of that sort in your practice?
So this is we're living in unprecedented times. There's a great future for apps and wearables, things that you can buy. At the end of the day, the most important thing that we can do is a kick in the pants and tell somebody that we care about them and that they need to make a change. The most important thing we can do is as analog and as old as time. If an app happens to be motivating to that patient, go ahead and do it. I have not found it. People will download the app. That does not mean that they will use it. What they need to know is that you care about them and that you will hold them accountable. And that can be done offline.
Okay, let's get to the global perspective. Now, do you think your patients are different and Indian patients are different? So from compensated to decompensated state, or both are the same?
I think that there are definitely ways in which there are differences. Differences that relate to environmental challenges. I think that the American kidney has been through more. I think that there are some unique cardiovascular complications that may be more enriched in one area or another, but I think we share more common ground than we see in terms of differences. And whereas I might have a more affluent patient population on average, I see profound disparities from urban to rural in terms of education as well. And our goals are uniform, which is to meet patients where they are. And as long as we understand what the patient is doing by asking them directly and then hold them accountable to incremental changes, we are on the right path.
So I think the message here would be clear that at the end of the day, patient is a patient for us, right? And diet, whether it's diet or whether it's exercise, it would remain the same for them. And maybe there might be little differences. Obviously, nutritional status might be a little different, or maybe the affluent society or the financial status might be different. But then overall, in the end, what matters is the kind of diet they take and the kind of exercise they do.
100%.
So, how do you assess a patient for malnutrition when they come to your clinic before you prescribe them a diet? How do you do that?
Yeah. Well, I think the first thing
Because
is that
I think it's very difficult at times.
Yeah.
You have a busy clinic which
Yes.
is going on, and now you have to assess, because in clinical practice it's very difficult to assess for sarcopenia and frailty.
Yeah. So I definitely think in a transplant clinic we should be routinely measuring frailty in an objective way. But when I see a patient with decompensated cirrhosis, it is safer to assume that they are malnourished as a function of the physiology of their condition. I do ask people about what they are eating. It does cost me between 1 and 3 minutes to figure out what they had in the last 24 hours, and that allows me to infer some degree of malnutrition. There is tailoring that is needed about the specific nutritional or exercise advice, but almost everybody with decompensated cirrhosis needs some kind of help. And it's easier to just assume that there's sarcopenia. If you see a large person with a large BMI, they might be hiding sarcopenic obesity. If they are frail, what we see with our eyes, wasting, temporal wasting, difficulty rising from the chair, it's obvious that they have sarcopenia. It's obvious that they're frail. I'll shake their hand. I'll assess for asterixis by hand grip. And if they're weak, that tells me something. That's all we need to do.
So I think the way the patient enters your room,
Yeah.
you'll be able to assess whether he's sarcopenic or not. And you don't need special tests for that, for that assessment. So as you said, that all patients with decompensated cirrhosis will be frail, will be sarcopenic. So it's better to prescribe them a good nutritionist diet as well as prescribe exercise to them.
Yes, 100%.
Okay, so what is your final message for the hepatologist about diet and exercise? So do you want the hepatologist to recommend, or you should take the advice of a nutritionist?
Okay, well, the highest level is the nutritionist. But to defer to nutritionists alone is an abrogation of our duty as hepatologists. We can say that it should be the primary care's responsibility, and in fact it probably should be, but that patient is before us for a reason that represents failures of the healthcare system. And it is our responsibility to ensure that we make sure patients leave our clinic knowing at least the basics, which is their protein prescription, the ways they should change their exercise, and the trade-offs in sodium restriction.
So I probably feel that the hepatologists have to be trained.
Yeah.
Obviously, they're seeing all the patients themselves, and they're going to follow up with them. So the hepatologist has to prescribe nutrition, hepatologist has to prescribe exercise, and they might take help of a nutritionist or a physiotherapist if required.
Yes.
That's what my thought is.
Yeah, and we agree.
So I think thank you very much, and it's been really nice talking to you.
Likewise.
And it's a pleasure having you here in Bengal. Thank you so much.